This program is brought to you by Emory University.
Good morning, everyone. Hope you had a nice weekend. Welcome to Heart and Vascular Grand Rounds. It is my great pleasure to introduce our speaker who is in person here today, Dr. Jennifer Tremmel, who is an associate professor and an interventional cardiologist at Stanford, and also the medical director of the Women's Heart Health Center there. And uniquely, she's also the director of the Chronic Total Occlusion Program. Dr. Tremmel studied psychology and French at University of Iowa and then stayed there for medical school, completed her master's in epidemiology from Harvard School of Public Health, followed by internal medicine and residency at Dartmouth, and then cardiology and interventional cardiology training at Stanford. She's also completed, I think I counted about 2 years of specialized research fellowship within the Prevention Research Center there. And currently, she's also the co-director of the Microvascular Network. And for those of you who don't know, that's a network within the United States and growing with everybody that's interested in the microcirculation that kind of gets together to not only talk about the research, but also how to take care of these complex group of patients, how to diagnose microvascular. And she's really been a pioneer in this area. She's also been a site PI of many research studies and continues to be. Also, I met Dr. Tremmel when I was at Cedars, and she had a K23 at the time studying sex differences in non-obstructive coronary disease. She's very well published in this area, very active with AHA, ACC, SCI, and also several writing groups. So I'm going to turn it over to Dr. Tremmel to talk to us about myocardial bridging in Anoca.
Thank you, Pooja. It's a pleasure to be here. So I'm going to give this talk from the perspective that everyone here understands Anoca. This is something that I think has hopefully permeated mainstream. You have Pooja Mehta here that should have educated you on that, and you had Olga Taleva as well. So we're going to kind of focus on one part of Anoca and the part that kind of still befuddles people somewhat. These are my disclosures. So I think an important place to start, particularly for fellows, is that we need to rethink coronary artery disease in general. When we talk about coronary artery disease, we all think about obstructive or plaque-based disease. And we usually split this into stable disease or unstable disease. And when it's stable, we say this is, traditional ischemic heart disease, stable ischemic heart disease. And if they have unstable or acute symptoms, this is our ACS or MI. But coronary artery disease does not include just obstructive disease. So now we also need to think about the non-obstructive aspect. And so if you have stable symptoms here, we're talking about Anoca or Inoca. So angina or ischemia with normal or non-obstructive coronary arteries. In the old days, we used to call this syndrome X because we didn't know what was going on. But now we do know what's going on, at least more so with these patients. And then if patients have unstable or acute symptoms, this is our Anoca or myocardial infarction with non-obstructive coronary artery patients. I'm not going to talk about this today. Unfortunately, this has traditionally been you're fine, which that is not the case. And so what we're working on with interventionalists now is that when patients come in with Anoca, that we do a little more of a workup in the cath lab as well as after to figure out the diagnosis in these patients and not tell them they're fine. So a little bit on terminology before we get started. So Anoca, there's Anoca and Inoca. I think of Anoca as really encompassing all the patients who have non-obstructive coronary disease that have angina or an anginal equivalent. When we say non-obstructive coronary arteries, we're talking about patients with a diameter stenosis less than 50% or a normal FFR, non-hyperemic pressure ratio. Inoca patients, to me, are the subset of patients who actually have ischemia on stress testing prior, so that you've demonstrated some ischemia. I will highlight that demonstration of ischemia is not a prerequisite for consideration of these non-obstructive etiologies. And unfortunately, a few consensus statements have come out, Europe, and then even our chest pain guidelines that said you need to show ischemia before you can consider this. And our stress tests, unfortunately, are not good enough in these patients, and you will often not find ischemia on traditional stress testing. We've shown that. It was shown at the Mayo as well. So it's important to remember that a normal stress test does not rule out a non-obstructive coronary etiology of angina. So you can't tell patients nothing's wrong with your heart arteries because they had a normal stress test. Also, you do not need an abnormal stress test to take these patients to the lab and do invasive coronary function testing. And having a normal stress test doesn't negate the need for doing that. So we've kind of come up with, in the microvascular network, coronary function testing is the overarching term for this invasive testing or workup that we do in the cath lab. So if you want to know everything about Anoca, we published in two parts, Jack's state-of-the-art reviews on Anoca, one really focusing on diagnosis, the other one on treatment in 2023. And these really kind of cover everything you need to know. It's important to understand that Anoca is a working diagnosis. It's not a diagnosis in and of itself. Your job is to figure out if a patient has Anoca, what actually is the underlying etiology. And so the workup, we start with a patient who has angina. Most commonly, these patients have quite typical angina. Sometimes it's somewhat atypical, but if it's something that people have already been doing stress tests on, this is somebody that we're thinking about their coronaries. So this patient has symptoms, and then you have some evidence that they don't have obstructive disease. Maybe it's on a CCTA, maybe they've already had an angiogram, maybe their stress testing is suggestive of non-obstructive disease. And then we take these patients to cath lab, we confirm that they have non-obstructive disease, and then we do coronary function testing. And coronary function testing includes looking for endothelial independent abnormalities. So that's when we put down the pressure wire and we look for a low CFR or an elevated IMR. And then we also do acetylcholine testing, looking for microvascular spasm, endothelial dysfunction, and epicardial spasm. And then we do IVUS and coronary physiology for myocardial bridging. And so today we're going to focus on just the right side of the screen here in terms of who are these patients and how do we work them up. So myocardial bridges. So myocardial bridges are troublesome. So they are common in the general population. So about 30% of people have them. And the vast majority of people will never have an issue, but a small subset will. And this is kind of like PFOs, right? And they're troublesome. And so you don't always know if a bridge is causing chest pain if you see one, and you really need to figure out, is this what's causing their problem, or is this simply an incidental bridge? And I know what everyone's thinking. And when you saw the announcement about grand rounds this week, you're like, myocardial bridges, whatever. I don't believe in it. I didn't used to believe in bridges either. We were all taught the same. We all went to the same medical schools, right? And we were taught that bridges didn't really matter. We can ignore them. And we were taught this for several reasons. So one of the big one that people like to say is, well, the coronary perfuses during diastole and this constriction is during systole. So this is not causing any issues. The other thing is people say, well, they were born with it. So why would they get symptoms later? Why doesn't it bother them from the get-go? Some people are like, bridges are rare. We never see them. They're not a problem. Other people are, bridges are all over. They're not a problem. But at the same time, if you read any article, and particularly these kind of review articles that get published in JACC or Circulation, there is always within the first paragraph the statement that these are generally considered benign, but they may be associated with angina, myocardial infarction, ventricular arrhythmias, and even sudden cardiac death, right? So we see that, yet we don't think much of it. So it's a problem. So I started to learn more over time about bridges, again, coming from the same starting place as everyone else. I started doing this testing in 2007 as I was finishing my fellowship. And as Pooja mentioned, I had a grant. I was looking at sex differences in Anoca, although we didn't call it Anoca back then. And I was also interested in plaque and how did plaque vary between women and men. And so part of my grant was to do the vascular function testing, but to also do IVUS on every patient. And this was unique. People were not doing IVUS on every patient. And what I found over time was I was finding a disproportionately high prevalence of myocardial bridges in these patients. And up to 60% of my patients had bridges compared to about 30% in the general population. And I was like, what is going on? This is quite odd. Are these bridges causing a problem? when I went to publish this particular paper in 2015, this was the one thing that upset reviewers, is they're like, this is weird. This doesn't make sense. We don't, the bridge thing, it really bothered people. Nothing else bothered them. This was the highlight of what bothered them. And I have to say, this is the only database ever like this at that time, right? So we had never consistently looked at Anoca patients with intravascular ultrasound. So this is what I saw. It was the first time. And so, we had to at least face it and figure out what's going on with these bridges. So a few kind of myth busters on bridges. So the first one, bridges are benign. So indeed, most bridges are benign or incidental. I would say I have 3 audience members. So one of you has a bridge. Presumably none of you have chest pain yet at this point. So most are not going to cause people problems. But it is true that there are some patients who have symptoms secondary to their bridging. The symptoms that we see, they're generally pretty typical exertional angina. A lot of patients can actually cite the heart rate at which their symptoms will start. Although several of them will also have it with emotional stress. And we think this is probably from the endothelial dysfunction that develops in a bridge. I had one gentleman only got it when he argued with his wife. And otherwise it did not bother him. What we also see is that over time, these symptoms tend to become more persistent. And so it's not as quick progressive as like a plaque, but it seems to be more over kind of like a decade. Their symptoms will only become more of an issue. We often hear it radiates to the back as well. And then we will see patients who have a lot of PVCs, and VT or syncope can be a presenting symptom. In addition to that, we will see patients who will come in with an MI. And the only thing that we can see, again, is that they have a bridge. It's probably most likely, again, from spasm within the bridge. And there are reports of sudden death. I have not studied any of the dead patients. So myth number 2. So bridges don't cause problems because coronary flow occurs during diastole. So this one, people love to come up and say this to me. I'm always a little bit giggly about this because this was disproven in 1994. So when people come up and tell me this, I'm like, you need to go look at the literature, right? So this was shown with Doppler. And what they showed is that these compressive effects actually go beyond systole and they extend into early diastole. That's what we see here in the second picture with this fingertip is actually blood flow coming into the coronary during diastole, yet there's still compression on the vessel. And then there will be a quick release and it creates this very classic fingertip formation. And, you can demonstrate this on any of these patients with a bridge. The more the heart rate goes up, we know that diastole shortens. And so there's even less time during that period for them to actually have true diastolic relaxation. So this is another myth. So the third one is, well, their symptoms should start from birth. So there are patients who will have symptoms at quite young age. So we actually have a pediatric bridge program. And I've studied patients as young as 10 who have chronic exertional chest pain. So they can cause problems early in life. Most of them, though, we will see it usually kind of 30s, 40s. I've had patients that haven't had symptoms until their 70s. So it can occur at any time. The question is why. There are certainly several theories on this. So one is this development of endothelial dysfunction or spasm within the bridge may start to cause problems in these patients. There's also a thought that there's negative remodeling that goes on, and we will definitely see that a lot of these vessels are very small within the bridge segment. There's invariably a proximal plaque that will form proximal to these bridges. And we've shown from flow studies that this is occurring at the spot where the flow comes in antegrade, and then you actually get retrograde flow from the bridge, and where that's hitting, you'll have a plaque. Even my 10-year-old had a plaque at that spot. So that can start to play a role. And then as we age, we know the LV gets thick and stiff, and this probably changes hemodynamics as well. And what I'm showing there in that picture is after the administration of acetylcholine, you can see that there's some constriction in this bridge. For people doing Anoca testing, you might just say this patient has a bridge, but that this patient has spasm, but in fact, this patient has a bridge with spasm in it. So they have two problems, not one, and it's important to be able to recognize that. So how do we diagnose these? So non-invasive diagnosis first. So bridges are most common in the LAD, but they can occur in any vessel. The second most common is going to be in the PDA. So they tend to form in the interventricular groove, but you can see them in the circumflex. You can see them in different places. LAD most common. So they can be initially diagnosed by stress echo or CCTA. Less commonly, you will on occasion pick up ischemia, usually anteroseptal with a nuclear or PET or cardiac MR. So stress echo, it's important to be able to read this. So at baseline on the left, everything looks normal. And what you see on the right is that there's actually this sort of what we call buckling at the septum, yet the apex is preserved and coming in normally. Okay, so this is a different look than if you had an LAD lesion, which should affect the apex as well. So I'm told by my echocardiography colleagues that echocardiographers see this all the time and they ignore it. But this actually means at least that there's most likely a bridge there. We've correlated this with the presence of a bridge. It doesn't mean the bridge is significant, but at least means a bridge is present. Our fellows can read this. This is actually very easy to read, and you will see this commonly. So look for this. So CCTA is very reliable in diagnosing the presence of a bridge. It's highly correlated with intravascular ultrasound we've shown. It's the non-invasive gold standard. It's typically, again, ignored, right? So our radiology colleagues have learned the same thing as all of us. Bridges don't matter, so they don't call bridges on CCTA. And so this actually requires a programmatic change if you want these to start being called. And so that's something that we had to do. There's a grading system for bridges. So 0 is none, 1 is superficial, which you can see an A there, particularly in the cross-sectional view. Then there's partial bridging, which is 2 in B, and then 3, which correlates with C, is full, where there's full thickness over the artery. Patients can actually have symptoms with superficial or partial or full, so you don't need a full thickness for symptoms. But certainly the more deep it gets, the more it becomes an issue. So CCTA also does not tell you if it's hemodynamically significant. It just says that you have a bridge. We've looked at CT-FFR. It was inadequate in describing if these bridges were significant. So right now we don't have that as an option. We also looked at muscle mass index, MMI, which is basically the length times the depth of the bridge, and did show that if the MMI was greater than or equal to 31, it predicted an abnormal diastolic fractional flow reserve with a reasonable sensitivity and specificity. And so that's kind of, you can get a hint, right? Like this is a long, deep bridge. It's probably more symptomatic than otherwise. So invasive diagnosis then. So turns out angiography is a poor way to identify bridges. So it's often missed. So sometimes you don't see it at all. Sometimes it's mistaken for just a mild narrowing. People say there's a little plaque there. Sometimes it's highly obvious. So this is a very obvious bridge. Hopefully everyone can see that. But this doesn't tell us if it's significant, right? So we'd all see this, we were like, oh my God, this is the most significant bridge I've ever seen. This actually was a pre-op patient, no symptoms. So presumably this bridge is not causing this patient any problems, and we wouldn't do anything about it. So you cannot tell on angiography. So the gold standard invasively is intravascular ultrasound. Intravascular ultrasound in this case is actually better than OCT. So OCT has great resolution, but it does not have great penetration. And one of the important points in diagnosing a bridge is being able to see this echolucent half moon sign, or this halo that's highlighted with the blue arrows that goes around the artery. And this is, we've shown histologically, these are the myocardial cells. This is the myocardium overlying the artery. And so sometimes you'll see it partial like this. Sometimes you'll actually see it all the way around the artery. You also need greater than 10% systolic compression on IVUS because any vessel has at least a little bit of vasomotion. So this is what it looks like on IVUS when we put it all together. Here you can see that halo on the left side, and you can see constriction of the vessel. So that's what it looks like on IVUS. And we can learn a lot by IVUS. So we have IVUS fellows. They can actually put together a whole map. And our surgeon will use this in the OR when doing unroofing. But you can get the length, you can get the depth, you can get the amount of compression of the vessel, you get the location of the bridge. Sometimes there's more than one bridge. You can see how many septals and diagonals are coming off, etc. I'm going to sneeze, I think. Sorry. Hopefully not. Okay, so the presence of a myocardial bridge in someone with angina, however, does not necessarily mean the bridge is causing the angina, right? So we can't just say, oh, it's your bridge. We have to do further testing. So it turns out resting indices or adenosine FFR are typically insufficient to determine if the bridge is significant. In some cases, these will be positive, and it's most commonly in the vessels that have this underlying restriction, right? They have negative remodeling. The vessel's already small to begin with. It's actually smaller in the bridge than it is proximally or distally, and you get this sort of fixed stenosis that gives you an abnormal resting indice or adenosine FFR. In most cases, however, you actually need dobutamine, and then you need to be looking at diastolic FFR or an alternative, basically looking in diastole to see if there's hemodynamic significance. So a little bit more detail about this. So myocardial bridges, they're dynamic, they're not fixed, right? So they need a different test than an obstructive lesion. When we do a fixed stenosis, we give FFR with adenosine or, again, a resting indice. Adenosine is simply a vasodilator, whereas these bridges really need kind of that dynamic inotropy and chronotropy to cause their problem. So that's why we use dobutamine rather than adenosine. And then again, for a fixed stenosis, what you'll see is that systole and diastole are equally affected. And so in that diagram, you can see how the coronary pressure has dropped in relation to the aortic pressure like this, and we can actually get a mean FFR. That's what we do when we're looking for an obstructive lesion. However, with a bridge, the systolic pressures actually stay exactly the same, and the diastolic pressure is the one that plummets. And so this is where all the action is, right? It's in diastole. So if you take a mean FFR like you normally would, you're going to underestimate the significance of the bridge. And so here you actually need the difference in diastole. So we call that diastolic FFR to tell if the bridge is significant. And this work was all laid out by Javier Escaned in 2003. And so we really drew on that paper because there wasn't much else in terms of assessing significance in these patients. Diastolic FFR, unfortunately, has to be done manually. There is no software to calculate diastolic FFR. And so it's something that we did for a while, but the question was, is there something easier? Because people out in the real world are not going to sit there and measure this manually. So as we got resting indices, which tend to focus a lot on diastole, the question was, can we use IFR? Can we use RFR to evaluate these bridges? And that was the question. So we have a paper coming out now where we tested dobutamine IFR. So they're not the resting indice, they're IFR and RFR with dobutamine. And so we tested dobutamine IFR, dobutamine RFR against our dobutamine diastolic FFR. So we did that in everyone to see how they correlated. And it turned out they correlated quite well. So dobutamine IFR and dobutamine RFR were reasonable substitutes. I will say dobutamine RFR was almost identical. So it was the best of the two. And it happens to be convenient as well because most of us are using the Corventus machine, which is where we get our microvascular testing. So we can just keep the wire in and do dobutamine RFR. But dobutamine IFR appears to be helpful. We use this cutoff of 0.76 for all of these, although we found that the RFR 0.76 was a good cutoff. IFR, trying to think, I'll have to tell you what our cutoff was, but it was a little bit higher to actually correlate with diastolic FFR. So this is what it looks like in the cath lab. So we have that pressure wire in, and then we give dobutamine. In this day and age, we start at 20 mics per kilo per minute. We give it for 3 minutes, then we go up to 40 mics, give it for 3 minutes, then we go to 50 mics. This usually reflects exactly what people do in the echo lab. This is what we do in the echo lab for a stress test. We give up to 1 milligram of atropine, and our target is 85% of the predicted maximum heart rate. So it's basically a little stress test on the cath lab table. And then we see what their RFR comes out to, looking to see if it's less than or equal to 0.76. I will say we give Zofran before we do this. I don't know why, but people seem to get nauseated when I do it in the cath lab. I guess this doesn't happen in the echo lab, but they do. And then once we're done, we give IV metoprolol to get them slowed down because it's usually uncomfortable, and kind of get the test over with. So what does this look like when we put it all together? So we do comprehensive coronary function testing at Stanford, and this is what we've advocated for as well in the consensus statements from the MVN. So we will start with our coronary angiogram to rule out obstructive coronary artery disease. Then we will do our acetylcholine testing. So we give acetylcholine directly in the coronary artery, and we're looking for endothelial dysfunction, and then we're looking for spasm, either at the epicardial or microvascular level. Then I put a workhorse wire in. I do intravascular ultrasound. I'm interested in, is there a myocardial bridge present? I'm also interested in plaque, and particularly diffuse plaque, right? There are patients who will have diffuse plaque. It just makes their artery look kind of small on coronary angiography, and they will have a low FFR. So this is another etiology of angina. And then I will put in my pressure wire. We'll do our CMD testing. And so this is when we get our CFR and our IMR. And then if we had seen a bridge on IVUS, then we will go ahead and do dobutamine for RFR. All told, if we end up doing everything with bridge testing, it takes about an hour to do this. Okay, so how do you treat these patients? So we found that nebivolol in particular is quite helpful. I think nebivolol kind of even over metoprolol is helpful probably for the vasodilatory properties, just because a lot of these patients have endothelial dysfunction in their bridge. So I will even switch people from metoprolol to nebivolol because we'll sometimes get an added response with that. As a second line agent, calcium channel blockers, particularly diltiazem, can be helpful. And then nitrates may actually be helpful in these patients. So this is another myth that's been around forever, that nitrates are contraindicated in these patients. And that actually came from angiograms back in the, 70s or something like that, where, if you give nitro in the cath lab, bridges always look worse. And so they said nitro makes bridges worse. And so we perpetuated that idea. I've had, maybe 4 patients over the years where I think they felt worse on a bridge, but for the most part, or they felt worse with nitrate. But for the most part, these can actually be quite helpful in patients. So don't hesitate, particularly if spasm was identified, to give a nitrate. I don't tend to like the long-acting ones like Imdur, but there's nitro time, which a lot of people haven't heard about, which is kind of a low dose, 8-hour nitrate that can be helpful during the day. So if they have a hemodynamically significant bridge and then they're on maximally tolerated medical therapy and their symptoms are still intolerable to them, we will offer them surgical unroofing. This does need an experienced surgeon, although at some point, if people are just starting, their surgeon will not be experienced, but they will become experienced. They can learn a little more about doing this well. One of the things we've seen is it's not always fully unroofed if your surgeon doesn't take the time in the OR to do that. So working with one, surgeon who's really going to dedicate to doing a good job on these patients is important. With regard to other therapies, stenting we know is potentially dangerous in these patients. There's definitely a higher risk of restenosis. You can get thrombosis in these stents. The stents can fracture. If you think about it, these vessels, again, they're small and they are constricted. And so when we stent, normally we can make a vessel much bigger. We can push that plaque out of the way. These vessels you can't make bigger because they are confined by a myocardium. And so if you put a stent in there, you basically got this little crappy stent inside a little vessel, which is why you see a lot of problems with stents. So don't put stents in bridges, please. Cabbage is not clearly helpful either. We've actually had several patients who had cabbage for this and have come back and still have symptoms. And we've had some cabbage patients actually go back to the OR and get unroofed because they couldn't stand how bad they felt. So our early experience with surgical unroofing showed a significant improvement in SAQ scores at 6 months. And so this was quite encouraging. You can see that at baseline, these people feel terrible, right? They have terrible SAQ scores with significant improvements. These are improvements that are beyond what you're going to see even with regular PCI or cabbage in atherosclerotic patients. So quite dramatic improvements in these patients. So I was going to run through a couple of cases. I have time to do a couple of cases. So this is a 60-year-old man, history of hypertension, who began having intermittent chest pain with exertion and emotional stress in his 30s. He's had several ER visits over the years. All of them have been unrevealing. He was told he had asthma. He was told he has anxiety. This should all be sounding familiar if you've had talks on Anoca. This is what happens to these patients. In the early 2000s, he had a negative stress thallium. In 2019, he finally had an angiogram, and they said there's mild narrowing in the mid-LAD. He was taking lisinopril for his hypertension and a statin. He'd been tried on metoprolol, but he had profound fatigue with that. So he came to see us, and we did a CCTA, and he did have a short segment of myocardial bridging in his LAD. So this layout that you see on the slide is basically what our radiologists now will put on all reports to talk about if there's a bridge, right? So if they have a bridge, they will note if there's atherosclerotic plaque proximal to the bridge, which, as I told you, is pretty much always there at about 20 to 30 millimeters proximal. They will cite the location of the bridge. They will say how long the bridge is. They will say what coverage we have on a bridge, what the muscle mass index is, and in his case, 51, so quite a bit more than 31. And then they'll say if there are septal branches within the bridge. The reason for this is because there's a feeling that there's probably some steel that's going on in these septal branches, which may explain why bypass is not helpful. So as you increase heart rate and the flow increases through the LAD, it's actually causing this Venturi effect in the septals. And so you'll see ischemia there. That's why nuclear or stress MRI, you will often see this septal ischemia as opposed to apical ischemia. So we told him, this bridge could be causing symptoms, but we don't know for sure, right? Because you haven't been studied. We said you could also have other things going on. You could have endothelial dysfunction or spasm. You could have microvascular dysfunction. We said we can try nebivolol or a calcium channel blocker. He wasn't on either. Or we could do invasive testing. At this point, I mean, he'd been having this now for 30 years or something. So he's like, I'd like to do invasive testing. We went ahead and started nebivolol in the meantime, and then we took him to the cath lab. So here's his angiogram. So we always use a diagnostic catheter to look at the right coronary, make sure it's non-obstructive, there's nothing going on. And then we go straight in with a guide because we know we're going to be doing vascular function testing in him. And so this is what his artery looks like. His LAD is laid out here. So if you're kind of used to looking at this, you would say, this probably is a bridge because you see this kind of diving down and then back up of the LAD. So this is something we see pretty commonly. But if you aren't used to looking at that, you might just say again, well, there's kind of mild athero through there, right? Because you don't necessarily see that milking on this angiogram at baseline. So next thing we do is we give acetylcholine. And the circ is a little bit over that, but basically it looked to us like a spasm pretty well, even with a low dose in there, just in that mid LAD. probably could have gone to a higher dose, but we felt like he had spasm in his bridge. And then this is with nitro. You can see the vessel looks better. You still can't see a lot of the systolic milking. It's just still smaller in that segment than it is proximally or distally. Okay, so let's see, we did acetylcholine. Then we put down the workhorse wire, and then we do IVUS. So here, hopefully you can see that halo kind of around 7 o'clock, extending around that. And then we got a length of this was about 17 millimeters. There was 31% compression. Halo thickness is basically how deep it is. So 0.68 millimeters. There's one jailed septal branch. We look at the max plaque burden, which was 48%, located 29 millimeters proximal to the bridge. And then the MLA of this vessel was 2.5, and that was in the bridge. So again, that's that negative remodeling. And I'm hoping when I touch this, it doesn't crash. Okay, good. So then we put down our pressure wire X, and we do our physiology measurements. So his resting IFR 0.87 and his FFR 0.78. So this was a situation where we actually saw a significant, normal kind of indices that we think of for plaque. And again, I think it was here, this negative remodeling and really kind of acting as a fixed problem in this patient. So theoretically, you probably could stop here and not do all the dobutamine testing, but we did go ahead and do that. We do that on everyone. You can also see the CFR is normal here at 3.2, but his IMR is quite abnormal at 43. So he has evidence of microvascular dysfunction by IMR. And then we went ahead and did dobutamine diastolic FFR. And we also did RFR. And so the RFR here, very significant 0.58, and our diastolic FFR was 0.59. And that's what we saw when we were studying both of these, is that they tended to be very similar, off usually by 0.01. So highly significant myocardial bridge. He wasn't still that interested in surgery. He felt that the nebivolol was helping a lot with his exertional symptoms. He was still getting some chest discomfort with emotional stress. So I added a low dose nitrate, overall doing well. And I think, he's somebody who's kind of put up with this for 30 years and is feeling quite a bit better than he did before. And so is not interested in unroofing at this point, which is certainly fine. Our job is to make people feel as well as we can. So that was his case. Second case, this is a 63-year-old female, no cardiac risk factors, who self-referred from Washington with exertional chest pain and dyspnea for over 10 years, and it was getting progressively worse. So she used to train wild horses, but she had to stop, and she was forced to retire from work about 5 years prior because of her symptoms. And they had basically progressed to become daily symptoms, and she could now only walk about 20 feet before she needed to rest. And so this is the kind of that example of this slow progression over time where things get worse. Her most recent outside evaluation showed a normal EF on echo. Her nuclear perfusion scan showed basal, infraseptal, and apical perfusion defects. And then she'd had a cath up in Washington showing an LAD myocardial bridge. And she was looking to see if there was something else she could do. She had used metoprolol with questionable relief, but she had to stop taking it because of hypotension. So same thing here, diagnostic on the right, looks normal, put our guide in to the left. So this patient bridge is angiographically apparent, right? And you can see that it's quite long. There's even kind of crinkling past the diagonal branch. So you can expect that this is a very long bridge. So next we give acetylcholine. So 20 mics, we went to 50 mics, we stopped at 50, felt this was diagnostic of spasm in the bridge. And then we gave nitro. The bridge is even more apparent here after the nitro. Next thing we do, we put down the workhorse wire and then do intravascular ultrasound. So she had a very long bridge, greater than 53 millimeters, very significant compression at 50%. Her halo thickness very deep. This is almost 2 millimeters. She has several jailed septals as well as a jailed diagonal. Max plaque burden is 41%, quite close to the bridge in this case. And then her MLA was 1.79, actually distal to her bridge, not within the bridge. Her resting IFR abnormal 0.85. Her FFR is abnormal, quite abnormal at 0.71. She had a normal CFR and IMR. And then this is her dopamine testing, not unexpectedly, very significant, 0.48 RFR, diastolic FFR was 0.49. So this patient basically had failed medical management. She considered her quality of life to be intolerable, and she chose to undergo surgical unroofing. This resulted in a resolution of her symptoms, and this can be quite dramatic, the surgical unroofing. So we are just now looking at our long-term follow-up with these patients. So this is unpublished data, but we have 150 that have SAQs kind of long-term. And so this is follow-up at 4 years. And kind of what our patient can hopefully expect is that we see long-term improvement in these patients. Again, quite dramatic improvements over that time. Their summary score improvements, a median change of 33, and 5 is considered clinically significant. We also, within this study, are looking at what about patients who decide to get unroofed versus those that decide not to. So we match 65 patients with a significant bridge who underwent unroofing with 65 patients who had a significant bridge but chose not to undergo unroofing, which would be kind of similar to the 2 cases that I showed you. We matched them on sex and baseline anginal severity. There were no significant differences in the anatomy of the bridges between the 2 groups, but we do see a significant improvement in those who are unroofed compared to those who are not unroofed, particularly with regard to physical limitation, anginal stability, anginal frequency, and then the overall summary score. So there seems to be a real benefit to this, and I would say, actually, of all the things we're treating, this is one where we can get quite a bit improvement for these patients, whereas sometimes like microvascular dysfunction, they maybe feel a little bit better with our medications, but not always this dramatic. So in conclusion, myocardial bridges are an important cause of Anoca and something that we need to be considering in these patients. These bridges can occur in isolation or in conjunction with other occult coronary abnormalities. So we need to do full comprehensive testing so that we can rule out everything and know exactly what we're dealing with and make sure we're treating everything that's wrong in these patients. Please remember, resting indices and adenosine-based indices are generally insufficient, so we can't stop there. We need to actually go on and do dobutamine testing in these patients. And then, ultimately identifying and treating these hemodynamically significant bridges, we've shown improves their angina and quality of life. So that's all I have, and I'm happy to take any questions. Thank you.
Thank you, Jennifer. That was very interesting. And you're probably the only one that I know who's studied bridges as much. I wanted to ask you for the resting, if you see somebody who has a resting bridge on an angiogram, have you given intracoronary acetylcholine and seen that they didn't spasm?
Yeah, you will see some where nothing will happen. It's always a little surprising because you expect something to happen, but there will be people that won't. And certainly there will be people that won't spasm. But sometimes you won't even see any significant endothelial dysfunction. And spasm per se is definitely not all of them. Yeah.
Because I'm wondering, places where they don't do the dobutamine testing in the lab, if we see myocardial bridge reported on a CT, for example, can we go, and if they're having symptoms, then can we go ahead and say, well, you probably have endothelial dysfunction. We're going to, use your nebivolol calcium channel blocker and kind of monitor the symptoms.
Yeah, I mean, I think in any of these patients, you certainly have the option of, trying to treat them medically before you do all the testing. I recognize that centers are just kind of getting on board with doing testing, and they don't always have kind of a champion to do the testing. So places are starting with what's most comfortable to them. I think, CMD testing is actually the easiest because we're all used to putting down a pressure wire. So a lot of places, that's all they're doing. And then they start to add acetylcholine once they get a little more confident in doing that and figure out how to get it to their cath lab. And, then they've got to do IVUS. So I understand it takes a while to kind of get up to doing comprehensive testing, but I think this is certainly a goal that we should all have. And certainly at, large academic centers like here, we would expect that you could do comprehensive testing. But there's nothing wrong with trying to treat patients empirically prior to invasive testing, right? Not everybody wants invasive testing, and it would make a lot of sense to do that. Yeah, and I mean, if you see a bridge, you can say, well, I think you'll probably have spasm, particularly if they're having rest pain. That seems to be indicative of them having some sort of constriction in the bridge as well.
And then, sorry, one last question is, if for people that you've sent for surgical unroofing, just dramatic improvements in terms of their SAQs.
Yeah.
Are there patients who didn't feel any better? Like, what percentage would you say where you sent? Because, surgeries, it's a big deal in terms of, undergoing that. And so let's say that they did have unroofing, but they were still having symptoms. What percentage
Yeah.
would you say?
Yeah, we actually looked at that. I mean, there was only one guy that was like our second case who swore he didn't feel any better. So literally everybody has reported feeling better. That does not mean everybody is reported feeling completely normal, right? So, but I would say at least, probably I think it's about 30% have complete resolution in symptoms. And then the rest will have a large improvement. We have not had patients regret that they did the unroofing that I'm aware of, because they do feel better. Some of that residual discomfort can be from these other underlying disorders as well, and which is why it's important to test everything. So you can say upfront, we're going to unroof you, but that will not fix your spasm as far as we know, right? Or it will not fix your microvascular dysfunction. And so we may still need to treat that. You may still have symptoms from that. There is a hope that over time, and I've kind of seen this, is that the spasm or constriction will improve. And it kind of makes sense because once you release that bridge segment, the artery can now have normal vasomotion. And so endothelial cells can actually start to line up normally and act appropriately. Because if you look, these are basically all disordered endothelial cells in this bridge segment. So it does make sense that there could be over time some reversal of this spasm. The microvascular dysfunction that we see in these patients, I often wonder if it's from the proximal proximal plaque. I don't know, but that's a possibility because it'd be like, well, why do they have that too?
The endothelium must take a beating in those spasm segments.
Mm-hmm.
It does. The surgeons say we've mistakenly gone in and tried to put a bypass graft into that. But say the walls, and maybe you've already covered this, but they say the walls are very thin and abnormal as far as muscle content. Is that true? Or do we know?
Yeah, I mean, I don't want to speak for surgeons. The walls of the myocardium itself.
The walls of the vascular walls, like when they
vessel.
open the vessel to put the bypass in.
Yeah. I have heard my surgeon say that they are thin.
Thin walls.
Thin and abnormal. Yeah. And so sometimes these bridges are actually this very thin fibrous material. So they can be quite thin. And so unroofing, you have to be careful. And I've heard sometimes like they'll pop this fibrous thing and the artery will kind of go ping. But yes, it's abnormal, right? It hasn't been getting to be a vessel the way it should have been since the patient was born.
So also the length of maybe you covered this also, but the length of the area of intramyocardial vessel, does that sway you as far as how you deal with this therapeutically, both medically and surgically?
Yeah.
Like sometimes they're just a few millimeters in length.
Right. Yeah. So certainly as I said, the longer or deeper, the more significant it likely is. You're right. I mean, on IVUS, every once in a while I'll see 2 millimeters or something. Like it was just this really quick bridge. Honestly, I will not study that because I'm like, it just can't, I mean,
Right.
Unless there's like massive constriction at that one location. But if it was sort of this flicker of bridging, I will not go on to study it. I will not tell them that this is a significant bridge. That happens from time to time, but is usually not, a major scenario.
In all the individuals who you've had to send for or unroofing, have most of them been the LAD, or have you dealt with any in the right coronary artery, or
Yeah,
you've seen one in an acute marginal branch?
Yeah, you can see them elsewhere. So the only ones we've ever done are in the LAD. I have not dealt with anybody that had angina and we found it somewhere else. Some of that could be we're not looking appropriately. So we also did a paper in conjunction with a prior fellow in Australia who looked at multi-vessel testing, right? And found that if we also look in the right coronary for other abnormalities, including microvascular dysfunction and spasm, we will actually raise our bar on diagnosis. So we're probably missing some like in the PDA. But at some point, I also understand that we have to get in and out of the cath lab. And so asking people to do this, I think, puts us at a great level in taking care of these patients, but also reasonable in terms of our time.
We had some chat questions, but maybe I'll barge in here before you get off. George Chang and I asked a question about whether you'd done any post-op studies after the unroofing and what you see.
Yeah, so at this point, the patients that have gone back for testing, which is very rare also, are patients who kind of don't feel very good. And they've typically been from somewhere else. And they've typically, what we found is they were incompletely unroofed, which is why I kind of stressed having a surgeon who's going to be thorough and really do all the unroofing. You can't half-ass this, so to speak, or these patients will continue to have problems. So we are trying to coordinate an evaluation where I do the testing, we then put the patient under, my surgeon comes in, does the unroofing, and when he's done, we wake the patient up and I do my testing again. And so we're ready for our first patient to do that because I thought that would be, people really would like to see that. And hopefully we only need maybe 15, 20 patients or something. And so, because I think that would be more meaningful. So yes, hopefully we will have data like that in the next couple of years. We'll see, but it's harder to get, right? And you have to get patients to agree to kind of all this testing and stuff all at the same time. And often this is a lot for them, but we're trying to look at that. Thank you. Okay, so that was your question on that. How important is patient symptom during like if they have symptoms while we're testing them? So we do pay attention to that. The diagnoses of spasm and microvascular spasm actually rely on having symptoms during testing. So I try not to sedate the patients too much, at least in the beginning, when we're doing the acetylcholine testing so that we can find out if they're having symptoms. In the US, we tend to sedate our patients a lot more in the cath lab than they do in other countries where they often don't sedate them at all. And so you do need to keep them a little bit lighter. With regard to symptoms during the stress test for the bridge, they almost all get it, but I don't know how significant that is. I often will say, is this like your pain? And it often is, but I don't use that as much. I mean, I kind of note it. Some patients were giving them a lot more sedation during that time too, so it may obscure how they're feeling. People also talk about adenosine and that causing symptoms. And I think a lot of this actually came out of CEDARS. I personally don't think getting chest pain with adenosine, I'm not sure what it means because so many people get it. So I don't think much of it. Some people think it might be heightened nociception. I'm not really clear on that. So I think it's worth paying attention, but I don't put too much weight on it. How do you pick bridges to study invasively? So these are patients who again have usually typical, so about 2/3 have typical, the other third have atypical symptoms. They have some coronary sounding component to them. They've already been stress tested. Like everybody's been looking for a coronary problem. They haven't found it. And so we're taking them to the lab to see if they have something or not. If there's a bridge, I will study it. A lot of these people, I don't know ahead of time if they're gonna have a bridge. We do comprehensive testing on everybody. Everybody has this exact same testing. In terms of non-invasive studies, again, you may not see anything. That's fine. Again, they have symptoms. If you don't do anything, they're just going to go to another cardiologist. They're going to get another stress test, right? So hopefully you've seen this data. These patients are getting tested up the wazoo. And basically, once they have this testing, we get definitive treatment. We get them on therapy. This testing stops. It actually saves money in the long run because patients stop going to ERs. They stop getting testing, et cetera. We answered that. Do you have any randomized trials or, yeah, so I mean, a cool trial, of course, would be that we do, a sham unroofing, right? So, uh, so we haven't done that, but that would be really cool. So people are often like, well, maybe this is placebo. I don't know. I've had patients who had bypass for their bridge and they still have symptoms, and then we unroofed it and it went away. So I don't know. I don't think it's all placebo. There is probably some placebo in this group who's struggling, and then we, listen to them. We take them to the lab. We give them a diagnosis. We try to help them. There's got to be some improvement. These patients feel crappy and nobody's paying attention to them. I don't think that's a bad thing, right? And a little placebo is not a bad thing. But do I think it's all placebo effect? Absolutely not.
I think you probably meant the beta point there.
Oh, doing that. Yeah. So yeah, you're right. Not unroofing. So yeah, so I have a fellow right now who got an AHA grant to put people on placebo versus not. This is with all Anoca patients because we need blinded trials with spasm and microvascular dysfunction as well. And so he's randomizing patients. So hopefully we'll get some data like that. I think the MDN, is starting a registry where hopefully we can get more centers doing the same test because we need more data on these patients. So lots of research left to be done in this group. Any role for CT-FFR, as I showed, we published a paper on this. It was not sufficient for diagnosing significant or hemodynamically significant myocardial bridge. It did not correlate with our invasive dobutamine diastolic FFR. So again, I think the problem here is you're not actually creating that kind of dynamic physiology with a CT. And so this doesn't work. So maybe at some point there'll be some sort of non-invasive way to test this, but it has not been discovered yet.
Okay, if there are no more questions, since we're about 5 minutes past, thank you again so much. That was very interesting. And thank you also for coming in person to do this.
My pleasure.
Spending
Thank
time
you.
with us.
The preceding program is copyrighted by Emory University.